Hi, good morning. Thanks so much for inviting me to participate in this session. Before I start, I do want to acknowledge the Medicaid Leadership Institute, and specifically for me and for Rhode Island, it is that program that allowed me the support and resources to start pursuing this notion of the intersection between the publicly financed healthcare system and the correctional system. So it's a great program, and I just need to give a shout out to that. So just some context for my comments first. Our efforts in Rhode Island are not specifically associated with the jail population. I wish that we had the luxury to be able to say that our efforts are so well defined and strategic that we can focus on jail. But we just sort of jumped in with corrections, and we're looking at all of the different opportunities across the settings: jail, probation and parole, as well as prison. And we're figuring it out as we go along. We are extremely fortunate in Rhode Island. A couple of structural aspects that make it a little bit easier for us to pursue this change. One is that we have I'm going to look to Steve for the correct word, but sort of a unified correctional system. So we don't have a county-based system. We have jails and our prison, probation and parole, all a part of the same unit. We also have incredible leadership from A.T. Wall, who heads up our correctional department, and also very much support from my boss, Secretary Costantino, to support Medicaid's connection to corrections. Additionally, our governor and General Assembly approved the Medicaid expansion. So we are one of those 26? Okay, states that are pursuing the expansion. So I was asked to talk to you a little bit about implementation, and despite those very positive structures, it's very messy. And I'm going to talk a little bit about some of the challenges we're having in, again, trying to not only ensure people leaving the corrections settings have access to insurance coverage, primarily through a Medicaid card, getting them enrolled with our health plans. We're very much a managed care-based Medicaid program, and then also ensuring that the healthcare delivery system is responsive to the needs of these folks. What has probably been the most positive development is the relationships that we've started to build between our organization, EO, Executive Office of Health and Human Services, and the Corrections Department and the managed care organizations. So we had worked with corrections in the past, primarily around ensuring that there was Medicaid coverage for inpatient hospital stays. And about once every year, we would have a meeting about changing suspension to changing from termination of eligibility to suspension, and it never went anywhere because it really was much too difficult to change the systems, and it didn't impact a lot of people. And outside of our behavioral health entity within the state, there was very little coordination, communication between the Medicaid state agency and corrections. And what is interesting for us now is to recognize the consequences of that. Not only the consequences of not having a relationship with them, but the consequences of the lack of financing for the services that these individuals need, primarily around substance abuse and behavioral health. And that system, we're finding now that we are starting to fund it in a much more comprehensive way, we're finding that it's the consequences of it being invisible to the Medicaid program has had a lot of, I think, negative consequences, and it's a bit delayed in its development, but we're very hopeful. So what did we do when we learned that we were going to expand in Rhode Island and that we had this incredible opportunity to start to impact the health and well-being of people leaving corrections? We identified 3 high-risk populations. And there's a lot of overlap between them: people living with HIV/AIDS, people with serious and persistent mental illness, and people who are justice involved. And we put together work groups of community-based organizations, our managed care organizations, corrections, and Medicaid, and started to work on the issues that we thought might come up with the expansion and the implementation of the ACA. So in terms of the eligibility process itself, our primary objective was, let's get the application process as part of the internal discharge process in prisons. And that was sort of what we focused on first. We had a lot of challenges just logistically getting our navigators into the system. Issues that we really didn't anticipate, because again, the underlying theme of my comments is we had no idea about the business processes and the business models and the organizational structure of our correction system, in the same way that they had very little access and knowledge about the way we did our business. So all of this is about a communication and learning a new language. So we didn't understand the difference between jail and prison and parole, and they didn't understand the difference between our aid eligibility categories, why someone couldn't access Medicaid. So it's been a very positive learning experience. But the security clearance, the lack of Wi-Fi access when people are in a correctional setting, we were coming at this from a customer service perspective. Let's use our online eligibility enrollment system, and let's go meet these folks. And we met with corrections. They're like, I don't think that's going to work. That scanner you have, we consider that contraband. So it's like, and believe me, we have a lot of those like Homer Simpson moments in Rhode Island. So we're starting to learn. We're starting to learn about the business processes and the places where we might be much more effective in reaching people. So we didn't think about probation and parole in the beginning, but we're starting to really think that might be one place we need to develop. We still need to catch people before they are released. So one of the surprising developments has been the activity of the Public Defender's Office, and they are cranking out those applications. And we never even thought to meet with them. So that has been a very surprising and positive development as well. I'm going to try not to get too in the weeds, but I want to talk a little bit about some of the challenges that we've faced with the technology itself. So the way that the new online enrollment systems, eligibility determination and enrollment systems are supposed to work is person types in their information, and then that information gets transferred up to a federal data hub and is either verified or not verified. And there's about 3 major points of data. One is your identification that has to be proofed, and a second is your incarceration status. We in Rhode Island had a lot of technology issues with the ID proofing piece. And it was especially sharp and stark with the correctional population, because if you have multiple addresses or you have out-of-date information, it became very difficult to have a person's identity proofed. So we had to do a work around that and developed a form with corrections that we would accept as a valid proof of identification. The other piece that was a challenge was the status of incarceration. Many of you may be familiar with this. Again, it was brand new to us. But our correctional system sends up to SSA on a monthly basis a list of people who have been incarcerated. And that data is used to stop the SSI payments and other payments. Now, corrections never sends an updated form to say when the person is released, because there is no business reason to do that. The point of that first transmission is to stop the payment, and then the person has to go and apply again. So, of course, that's the data source that we ping for incarceration status. And it never changes. Once you're in there, it never goes away. So we have been working closely with the SSA to see if we can somehow fix that problem, and it looks like we won't be able to do that. So, yeah. So we are doing a local workaround where we will have to trump the federal data with our own state data. So another unanticipated problem. We thought it was going to go so smoothly. And then if I just have a couple of minutes, I want to touch on the issues that we're finding in terms of the healthcare delivery system itself and its preparedness to meet the needs of these folks. One thing that was very, very clear is the need for health literacy for these men and women. The other speakers have talked about the numbers of people who never sought treatment before jail or incarceration, and we are developing with Corrections a program to, and I know it's in place in several other states, but a program to increase health literacy and education around Medicaid benefits, Medicaid access to services. One of the, I talked about substance abuse and behavioral health treatment. Our very preliminary findings from one of the health plans we work with is that they looked at the top 10 inpatient medical diagnoses specific to the expansion population. The first, the top was alcohol withdrawal. The second was acute pancreatitis. And the ninth was poisoning by unspecified drugs. This was brand new to us. We hadn't seen those diagnoses in the top 10 before. So one of the positive things about the data is that people are actually getting treatment. It's in a hospital, but they're getting treatment to the services. On the other end, we know that we need to get people into residential treatment as soon as they are discharged. And residential treatment hasn't been financed in a robust way by Medicaid. So, and we're also, as I said, a managed care state. And the problem is people are not enrolled in a managed care plan on the day that they leave prison. So we are working hard to ensure that they're eligible for Medicaid and they have a Medicaid card, but they're in what we call our fee-for-service system. And because of this exclusion in payment called the Institute of Mental Disease Exclusion, IMD exclusion, the number of beds we have that we can pay for directly from state to provider payment is very limited. I don't know how many of you are aware of this IMD exclusion. If Tony West were here, I would really request that the groups that they're working with look at this IMD exclusion because it's a real barrier for us to getting folks into residential treatment. We are working with our managed care organizations, though, on case management protocols, on the transfer of data as well. So just to end, we view this opportunity in Rhode Island as one of the major public health interventions in the state in decades. And we think that it's really a great opportunity for us to improve not over the overall healthcare system, but specifically substance abuse and mental and behavioral health. So thanks very much for the opportunity.